So now we'll have Dr. Leena, who will be talking to us about anterior capsule related complications and challenges and how to overcome them.
Good morning all. At the outset, I would like to thank Dr. Ashish for giving me this great opportunity. I appreciate the efforts of the organizing committee in conducting such a wonderful conference. So I'll be talking about anterior capsule challenges. The main ones I'll be dealing with is a capsulotomy in an intumescent cataract, what do you do to prevent a AF sign and when it occurs, what to do in case of a rhexis escape or tear, and also how to prevent difficult rhexis situations. Now, in an intumescent cataract, capsulotomy is a challenge. Why? Because we have a thin, fragile anterior capsule. There is too much intralenticular pressure. There is leaking of liquefied cortex, which makes a difficult view for the rhexis. There is no red reflex, and the antechamber is shallow. So when you make a first nick on the intumescent cataract, as you all know, the milky cortex escapes and you cannot see the rhexis margin. So what you can do is you can either aspirate with the cystitome that you have in hand, or you can use the viscoelastic gel to just clear out the cortex, liquefied cortex, and continue with your rhexis. How do you manage intumescent cataract? You can do any of these methods. Coming to double rhexis. So first you make a micro rhexis with the help of your cystitome. Remember to pull towards the center, and the margin of the rhexis does not extend to the periphery. So once the micro rhexis is completed, you need to decompress the lens. You can use a Simcoe to aspirate out the cortex, the liquefied cortex, from the periphery towards the center. And once that is done, the lens is decompressed. Then you use soft shell technique. You flatten the capsule with viscoelastic. Use micro rhexis scissors to enlarge the rhexis. So when you cut, you should cut tangentially at the micro rhexis. And once the cut is formed, you have a flap with which, and with a forceps, you enlarge the rhexis to adequate size. When you decompress the lens, you should also remember to decompress the posterior cortex also. How do you do that? You can do it by different methods. You can tap the nucleus down. You can move the nucleus or rock the nucleus sideways so that the posterior cortex gets loosened and it comes anteriorly. You can twist or dial the nucleus, or you can even do a bimanual irrigation. Once that is done, you can continue with your double rhexis. You can do a triple rhexis if you think the rhexis that you formed is small. That is, after IOL insertion, you can inject viscoelastic, make a small tangential cut on the rhexis margin, and then enlarge it all around to an adequate size. Next is a snail track rhexis. Here you make a small rhexis, form the anterior chamber with viscoelastic, go around and enlarge circumferentially in small widths. The only thing you have to be careful in this is the flap of the rhexis that you have cut will actually be elongated. Make sure it doesn't come out to the side port. You can actually cut it, shorten the flap, and then continue with your rhexis and make it an adequate sized one. You can do a lens decompression where with a 25 gauge needle you go into the cataract, aspirate the cortex, liquefied cortex, and then once the intralenticular pressure is reduced, you can continue with your rhexis. Now, an Argentine flag sign is formed when there is too much intralenticular pressure in an intumescent cataract, and this causes an uncontrolled radial tear of the capsulotomy. So once you have an AF sign, what do? You cut the rhexis on either side of the AF flap and with a Vannas or micro rhexis scissors, and then enlarge it with the help of a forceps. Make sure that the capsule is flat and you use viscoelastic. So once your rhexis is done, this is how your rhexis would look. Rhexis tear, there are studies that say that a capsule tear, there's an incidence of about 0.79%. It can occur at any stage of your cataract surgery. The tear can be limited. It may reach up to the equator. The worst part is when it crosses over to the posterior capsule. So when there is a rhexis escape, or when you see the rhexis margin extending towards the periphery, you can do a Brian Little's maneuver. Here what you do is you unfold the capsule back and then you pull towards the center or away from the direction of the tear. Now this is another video where you can see that once the rhexis is gone towards the periphery or is going towards the periphery, you just flatten the capsule, unfold the capsule, fold back the rhexis flap, and then with the help of your rhexis forceps, pull it towards the center or pull it in the opposite direction of the tear. Yeah. Now, once the rhexis has escaped to the periphery, you just use your forceps, try to bring it back by the Little's maneuver. You see that the capsule is not moving, stop it there, because you'll be further extending the rhexis tear towards the equator and beyond. So what you can do is, you can use a rhexis scissors, cut the flap of the capsule at the region of the tear, and then with the help of a forceps, just enlarge it to an adequate sized rhexis. You cut with a rhexis scissors or a vanas, and then enlarge with the help of your forceps. Or what you can do is, you can start off the rhexis from the opposite side and come and join to the tear where the rhexis has extended. These are the two methods how you can deal with the rhexis escape to the periphery. Now, how do you prevent this difficult rhexis situation? Every time you do a rhexis, make sure that the IOP is not high, there is no positive pressure. You can use pre-op hyperosmolar agents in case of an intumescent phacomorphic cataract. The speculum should not be too tight. You prevent eye movement, make sure that the globe is well fixated, you have a very good red glow. Stain the capsule with tryptophan blue so that you have a better view of the capsule and there is reduced elasticity of the capsule. Keep the anterior chamber deep and well formed. Use highly viscous OVD, you can use the soft shell technique. Always keep the capsule flap flat over the anterior capsule when you're doing the rhexis. So remember that when you are doing your rhexis, always keep viscoelastic ready. You can keep viscot with you or a rhexis forceps and scissors ready, because any time your rhexis can extend to the periphery. So to prevent, make sure the anterior chamber is well formed. You flatten the capsule, release intralenticular pressure in intumescent cataract, and once the rhexis has escaped to the periphery, it's better to use a side port, because to the main port the anterior chamber becomes shallow and the visco escapes. Flatten the capsule, unfold it and pull centripetally, and if it does not come, cut and continue your rhexis. My acknowledgements, references. Thank you.
Thank you, Dr. Leena. Dr. Leena is an associate professor in Believers Medical College, and she's also a phaco trainer and a trainer for PGs and medical students in Believers Medical College. Thank you, Dr. Leena.